Good afternoon, everybody. I'm thankful to the organizers for giving this opportunity and some of the information I want to give already covered by Dr. Shishkant. So my topic is mortality in acute coronary syndrome patients post-intervention, important role of antiplatelet therapy. So these are the agenda I will discuss. ACS pathophysiology, mortality with post-MI, antiplatelets in acute coronary syndrome and supporting trials, and what is the real world evidences and what is the meta-analysis of data that is saying and guideline recommendations. So as we know, the acute coronary syndromes is a group of clinical symptoms compared with acute myocardial ischemia. If you can recollect our pathology, it is basically a ruptured erytheromatous plaque with a degree of thrombus. If it is a total occlusion, it leads to STEMI. If it is a subtotal occlusion, it will lead to unstable angina and non-ST elevation MI. And of course, without thrombus, it is the stable syndromes. Of course, unequivocally, dual antiplatelet therapy is most important ACS, which will reduce the risk of ischemic cardiac events, but at the expense of increased bleeding. As we know, the arterial clot is a platelet-rich clot. That's why dual antiplatelets play a significant role. So the acute coronary syndrome, which contributes significantly to the mortality and morbidity related to cardiovascular disease. And almost both ST elevation and non-ST elevation contribute to 50% of all deaths due to cardiovascular disease. And among 1/3 of STEMI patients die within 24 hours, it is contributing to 33%. And in non-ST elevation, almost contributing to 15% of the cardiovascular deaths within 30 days are having another non-fatal myocardial infarction. And this is the most important an observation of insights of a CREATE, which is a ACS registry in India. And this is a prospective registry study in 89 countries, 89 centers from 10 regions and 50 cities in India, constituting 20,937 patients. ACS was diagnosed in 60.6%, that is a STEMI, and with a mean age of 57.5 years. And risk factors being smoking in 27.9, diabetic in 30.4%, hypertension 37.7, and past history of MI 17.5%, and 30-day mortality being 6.7%. And surprisingly, the antiplatelet therapy, if you take monotherapy, was with aspirin was given a majority, that is more than 80%, but under usage of the clopidogrel, that is almost around 15%. So as it was described by Shishkant, it reached registry, the cumulative incidence of ischemic events of cardiovascular death, MI and stroke increases from 1 year in the extended up to 4 years. It is almost to the tune of 15.1%. And this is the mechanism of action of different antiplatelet drugs. And as we know, the aspirin is a cyclooxygenase inhibitor, it reduces the prostaglandins. And 2B3 blockers by blocking the receptor, that is eptifibrine and tirofiban. And we are more interested in P2Y12 oral inhibitor, which is a ADP receptor antagonist. The common drugs which we are using in practice being the clopidogrel, prasugrel and ticagrelor. And these are the comparative differences of pharmacodynamics and pharmacokinetics of oral P2Y12 inhibitors. The most standard, that is clopidogrel and prasugrel and ticagrelor comparison. We know the dosage and all these. The most important, clopidogrel, prasugrel is a prodrug, whereas ticagrelor is an active drug which directly inhibits the receptors. And most important is it is a metabolism dependent, with the CYP phenotype is more prevalent in clopidogrel. That is the cause for its variable response, whereas not seen in prasugrel and ticagrelor. And inhibitory platelet activity percentage, almost clopidogrel is efficacy only 50 to 70%, whereas the prasugrel and ticagrelor more efficient, inhibiting of 90% of platelet activity. And time to reach of inhibitory action of a platelet activity is low with the clopidogrel, that is, it will take a long time, 2 to 4 hours, whereas in half an hour, maximum percentage of platelet activity is seen in ticagrelor. And coming to the individual drugs comparison sake, clopidogrel is a thienopyridine, which is a prodrug and competitively binding with ADP receptors, but the main disadvantage of this standard drug is slow onset, less potent of inhibition, poor absorption, drug-to-drug interactions is more, and affected by genetic pleomorphism. So clopidogrel variable response is seen in the population. And even the standard, the low response is due to reduced bioavailability, genetic variability, basal individual variability in accelerated platelet turnover, and that leads to variable and insufficient responses to the clopidogrel. And clinical relevance of this clopidogrel non-responsiveness and which is affecting the different functional parameters of the platelet function, that is a reduced inhibition of the platelet aggregation in Muller et al. Study and increased P2 valvular reactivity in Barang et al. Study. Ultimately, all this leads to the stent thrombosis that is clinically relevant. And as it was described, most important is a dual antiplatelet therapy with the clopidogrel, which was unequivocally more efficient than the single antiplatelet aspirin in a landmark trial like CURE, PCI CURE, COMET and CHERISH studies. All these it was shown it reduces almost 9% of risk reduction to 20% risk reduction of the cardiovascular events, that is stroke and MI as well as death. And of course, the slight increase in the bleeding rates also. Coming to the prasugrel, this is also thienopyridine derivative which is a prodrug, and it is also have a competitive binding of ADF receptors, and less drug to interaction is there with this, but advantage of being rapid onset, potent inhibition of the platelets without interindividual variability, and effective in clopidogrel non-responders, especially young patients with MI. This is more useful, but it has its own limitations, which is not recommended in elderly patients of 75 years and old and underweight patients and history of stroke and TIA patients, and it is not indicated without knowing coronary anatomy. And the efficacy of the prasugrel is unequivocally proven in Triton-TIMI 38 study. Compared to the clopidogrel, it reduces the event rate of ischemic events almost 9.9 compared to the clopidogrel 12.1, but it was slightly increase in bleeding events compared to the clopidogrel. And the most important is coming to the rate of cardiovascular death with prasugrel, there is no significant reduction compared to the clopidogrel. Coming to the ticagrelor, which is a different chemical, that is a cyclopentyl triazole pyrimidine drug chemically, and this has a direct acting on P2 receptor acting. It is not a prodrug, it is directly active drug. It doesn't require any metabolic activation. That's why it has a fast onset of inhibitory effect within half an hour of loading dose, and it is a first reversible binding oral ADP receptor antagonist, and it has a more consistent platelet inhibition compared to the clopidogrel. And its response study, which was showing the percentage of inhibitory platelet activity measured in non-responders, it is showing consistently inhibition of platelet activity uniformly throughout from day 1 to day 28 compared to the clopidogrel. And this is a landmark randomized control study showing the efficacy of the ticagrelor compared to the clopidogrel in reducing the composite events of the cardiovascular death, MI and stroke. Almost started at 30 days, and the benefit was continued up to 12 months. And this is the plateau invasive study also subgroup, which was showing reduction of the composite endpoints of cardiovascular death, MI and stroke in ticagrelor compared to the clopidogrel. And of course, the efficacy is more, but at the same time, the safety, that is bleeding risk, it is almost comparable with the clopidogrel, that is indicating safety. And coming to the mortality benefit seen with ticagrelor, irrespective of initial treatment strategy, both total cardiovascular mortality as well as all-cause mortality, it is showing its efficacy, whether it is initial invasive treatment or initial conservative treatment or bypass surgery, it is showing efficacy compared to the clopidogrel. And this was covered by Dr. Shishkant. It is an extended study of Pegasus-TIMI 54, where the ticagrelor 60 milligrams BD along with the aspirin 75 and 50 and with 90 milligrams and placebo minimum period of 12 months follow-up every 4 months for 1 year, then semi-annually, and comparing the composite events of cardiovascular death, MI and stroke, it is showing consistently a risk reduction of 7.7% compared to the placebo. And effect of ticagrelor in patients with prior MI in approved European trial, it was shown consistently superiority of reduction of the both cardiovascular mortality as well as the all-cause mortality. Then coming to meta-analysis of the ticagrelor and oral P2x12 receptor blockers, almost 9 randomized controlled trials encompassing 106,288 patients which was analyzed Ticagrelor as having of being ranked the best therapy in reduction of the MACE events compared to the prasugrel, which is 79% of probability. And after treatment ranking also, this is a statistical analysis showing ticagrelor reduced the all-cause mortality almost 95% of probability is the best P2Y12 inhibitor in preventing the all-cause mortality compared to prasugrel and clopidogrel being 61% and 41%. And best therapy for preventing the cardiovascular mortality, the ticagrelor did best. And preventing the recurrent ischemic events also, the ticagrelor did better, 90% compared to the prasugrel 70% and clopidogrel 33%. So the conclusion of this meta-analysis of the study showing ticagrelor decreased major ischemic events, both cardiovascular as well as all-cause mortality, without increasing the major bleeding risk compared to the clopidogrel. And ticagrelor significantly better than prasugrel and clopidogrel systemic review analysis, almost 22 studies of total 35,004 participants included in the systemic review. It was shown the composite events of recurrent events in ACS when compared to clopidogrel, this did better compared to the clopidogrel, which is almost in accordance with the Plateau study. Then real world evidence. So this is a Swedish registry showing benefits of ticagrelor in practical compared to the clopidogrel. Almost a risk reduction of events, it did better compared to the clopidogrel. And coming to the Denmark registry, almost 60,386 patients with ACS were included in this. And the conclusion is associated with the low risk of the ischemic events, both MI as well as stroke or death rate, but slightly increased risk of bleeding in this registry was observed. Coming to Taiwan registry, in the real world Taiwan patients, ticagrelor seemed to offer better anti-ischemic protection than clopidogrel without increasing the rate of major bleeding. So what are the guidelines saying? Once in acute coronary syndrome, invasive arm, it was post-PCI, whether with DES or BMS or drug-coated balloon. If the bleeding risk is not there, then we have to give the oral P2Y12 blocker along with aspirin up to 12 months. It is class 1A indication. As Dr. Shishkan told, if still there is no high bleeding risk score, you can continue beyond 12 months. It comes under class 2B indication. Whereas the high bleeding risk is there, you have to give oral P2Y12 along with aspirin up to 6 months. This comes under class 2AB indication. Then coming to 2017 ESC guidelines, the potent P2Y12, prasugrel and ticagrelor, if they are not available clopidogrel, they have to be given post-PCI up to 12 months. It comes under class 1A indication. Of course, aspirin is recommended as soon as possible for all without contraindication comes under class 1B. And the duration up to 12 months, it is unequivocally whether it is a post-PCI or medically managed, the oral P2Y12 inhibitor should be given along with aspirin up to 12 months. If they are not available, then you can give clopidogrel. Then switching over, it is a focus update is recommended that in patients with ACS who were previously exposed to clopidogrel, switching from clopidogrel to ticagrelor is recommended early after hospital admission at a loading dose of 180 milligrams irrespective of timing and loading dose of clopidogrel unless contraindication ticagrelor, it comes under class 1B indication. Of course, additional switching between oral P2Y12 inhibitors may be considered if there is intolerance. According to the proposed algorithm, it comes under class 2BC indication. And this is the ESC 2018 guidelines showing in non-ST elevation MI, the prasugrel P2Y12 naive patient who proceed to PCI is to be given in 60 milligrams loading followed by 10 daily dose. It comes under class 1B. And ticagrelor irrespective of the pre-treatment and revascularization strategy, you have to give 180 milligrams loading followed by 90 milligrams twice daily. It comes under class 1B. And clopidogrel should be given loading 600 milligrams and followed by 70 milligrams daily dose when prasugrel and ticagrelor are not available in the shelf or in the hospital or they are contraindicated. It comes under class 1B. And most important, in case of ST elevation MI, aspirin is recommended for all patients without contraindication as initial oral loading dose of 150 to 300 1A indication, and a potent P2Y12 receptor blocker prasugrel ticagrelor or clopidogrel if they are not available or contraindicated before PCI should be maintained over 12 months unless they are contraindicated such as excessive risk of bleeding, it comes under class 1A indication. And newer antiplatelets versus clopidogrel, the era of the primary angioplasty, still whether clopidogrel is still in the scene, probably no is the wise answer. But in the case of a real self-funded health sector, if you can compare the cost between clopidogrel, prasugrel, ticagrelor, almost clopidogrel is more cost effective. So these might be the possible usage of clopidogrel in the real world, where it is a cost initial as well as long term it is cost effective. And clopidogrel may be given in rare subgroup of patients who undergo primary angioplasty without stent, which we encounter in some of the cases, and foreseeable high risk of bleeding, and clopidogrel may be the drug of choice in those subgroup. But when you are switching over from clopidogrel, from ticagrelor or prasugrel, for patients who are receiving ticagrelor, give the first dose of clopidogrel 12 hours after the last dose of ticagrelor to give 600 milligrams loading dose of clopidogrel to all such patients. Those who are receiving prasugrel within less than 5 to 7 days, load with clopidogrel 300 milligrams after 24 hours the last dose of prasugrel. For patients, for patients who have received prasugrel for more than 5 to 7 days, start clopidogrel 70 milligrams for 24 hours after the last dose of prasugrel. Thank you.